But I want to thank everybody for coming and welcome our two speakers, student Dr. Syed and student Dr. Edwards. SD Farzeen completed her BS in Neuroscience from the University of Texas at Dallas before joining KCU, where she has served as a student ambassador since 2017. And student Dr. Carli Edwards graduated from the University of Utah with a BS in mathematics and a minor in chemistry and pediatric research. They were able to, in their third year, gain experience under KCU's Gautam Desai through the Global Health Rotation with Banyo's Kenya mission. While there, they evaluated barriers to HPV vaccination and worked to provide free healthcare and education to local Kenyan communities. They were able to educate local school children on sexual education, including STIs and HPV vaccination. This topic was the focus for their global health project, which won them first place in the AOA's Bureau of International Osteopathic Medicine in the abstract competition for research category. Both the poster and the abstract will be uploaded to the American Osteopathic Association's Biome official website page and presented at the OMED 2020 conference that was this year. So we are very honored to have both of them here to present and shed some light on what the global health rotation allowed them to do. So I will turn the mic over to you guys and thank you for being here. If you guys could mute your mics and just wait until the end and we'll field questions then. Thanks.
All right, I will go ahead and share my screen. Let's see. Let's see here. All right, can everyone see that okay?
Yes.
Okay, sounds good. Thank you for the introduction, Shelley. So hi, my name is Farzeen Syed. I'm a fourth-year medical student at Kansas City University, and today I'll be presenting to you alongside my research partner, Carli Edwards, our project assessing barriers towards implementing human papillomavirus vaccines in rural Kenya that we conducted with the help of our faculty advisor, Dr. Gautam Desai, during a global health rotation last November in 2019 in the Wanjaya village near the western Kenyan city of Kisumu. Next slide, please. So before we dive in, I wanted to give you all a bit of background of how we got involved with the project and some insight on the process. Dr. Gautam Desai, and the next slide, please. Dr. Gautam Desai, our faculty advisor, leads trips to the Dominican Republic and international rotations to Guatemala and Kenya. One way to be a part of these trips is via the Global Health Track or independently applying and or setting up rotations during your clerkship years if you're in good academic standing. I initially became interested in the topic while I was applying for the Global Health Rotation in Kenya. I'm really interested in cancer prevention and hope to be an oncologist one day. So while I was working on my application, I researched what cancers are prevalent to Kenya and was surprised and at the same time disheartened that cervical cancer was a leading cause of female cancer-related deaths. So this is a cancer that we in the States have done a relatively good job in controlling with screening guidelines through pap smears as well as the HPV vaccine. So I wanted to use my time during the rotation to gather more data on this topic.
Yeah, and similarly, one of the things that brought me to KCU was the Global Health Program. I knew I wanted to participate in one of the Global Health outreach trips, and when I heard Farzeen was going to Kenya as well and interested in doing research on cancer, I thought the topic sounded really interesting and asked if I could help, and I was super grateful that she let me. So I have a strong interest in pediatric oncology, and I was also similarly surprised that cervical cancer, which is something that's pretty well screened for in the US, was such a problem in Kenya. And I was really interested in learning more about this topic while in Kenya.
So to give you all a little bit of background, cervical cancer is a leading cause of death among females in Kenya, accompanied by major barriers to prevention, such as limited resources, lack of knowledge, poor access to healthcare, and stigma regarding cancer. According to the American Association for Cancer Research, since the introduction of the HPV vaccine, there's been a drastic decrease in the incidence of HPV-related cervical cancer and other HPV-related cancers. So while pap smears are effective screening tools to help prevent the progression to cervical cancer, the subsequent steps are not feasible in resource-limited rural regions to prevent the advancement to cervical cancer, let alone treat it. So many rural areas do not have the resources or training to manage and treat advanced abnormal pap smear results. And in particular, there's very little data about access and barriers to the HPV vaccine in rural Kenya. Next slide, please. So the study aims to take an osteopathic approach by improving wellness via disease prevention in the community surrounding a rural Western Kenya clinic through increased education on cervical cancer and HPV vaccination benefits. We wish to do this by examining the attitudes, practices, and barriers related to cervical cancer prevention in the rural region of Kenya in hopes to aid in the establishment of a future HPV vaccine program. We hypothesized that by increasing awareness on the topics of cervical cancer and its prevention among school-aged children, we then can challenge any stigma regarding screenings and vaccination. And then we decided to extend our hypothesis further to the adult female population and hypothesize that patients, once educated about the HPV vaccine, would be willing to receive it to prevent the development of cervical cancer. Next slide, please. So just to give you guys a little bit of background, the Mama Palista Medical Center is a nonprofit organization in the Wanjaya village near Kisumu, Kenya. Kisumu, Kenya is on the more western border of Kenya, and it's a port city off the shores of Lake Victoria, one of the largest bodies of water that we have. The Mama Palista Clinic offers free healthcare with the help of volunteers, medical professionals, and medical students. The patients will arrive at the clinic and are first seen at the triage site where their vitals are assessed and their chief complaints are noted down. And then afterwards, they're directed to the healthcare volunteers to be examined for further medical care. And throughout the kind of like the C-shaped clinic that you can see, there is there's an OB-GYN ward, there's a small inpatient ward as well that houses about maybe like 6 to 8 beds from what we can remember. There's also a lab where they do testing and a small pharmacy as well. The clinic is located about an hour and a half outside of the major city of Kisumu. So it's about 45 minutes off the main road. And while you're traveling down the main road, it's between like rice fields and between some mountains too. So it takes some time to make sure that patients can get more advanced treatment. Next slide, please. So conducting a research project, especially a global research project with human subjects, does take time and a lot of planning. Prior to even implementing our project, we had to obtain IRB approval through the IRB committee at KCU. And this was especially important because we were working with human subjects, including minors. We communicated with the clinic's manager during the approval process to obtain parental consent for our adolescent age subjects and permission for us to conduct the study at their clinic. So with part one evaluated the impact of our educational intervention on school-age children 12 to 18 from the Wanjaya village regarding HPV transmission and its prevention. After gathering volunteers with the help of the clinic's healthcare manager at Mama Palista, we administered a pre-educational seminar survey followed by a 20-minute presentation on sexual health, STIs, and a specific focus on HPV. Afterwards, we administered the post-survey. Both surveys, both pre and post surveys, were the exact same and asked questions such as, do you know what a vaccine is? Have you ever heard of cancer? And so forth, like that's presented on the slide. When developing the seminar content, we made sure to work closely with the clinic staff and clinic manager to ensure that our content was culturally appropriate and sensitive for the community and for our subjects. It was important for us to develop the content together with the staff and for the clinic to use in the future, because in the end, we were guests or / volunteers only visiting for a short period of time. And then on the next slide are some examples of the slides that we used for our seminar. We try to keep the language as basic as possible to ideally minimize any confusion or any loss of translation. Next slide, please. So part 2 was subdivided into 2 further parts, 2A focusing on the female patient population and part 2B focusing on the healthcare providers. 2A focused, like I mentioned, the female patient population aged 18 to 65 who presented to the clinic for care and wished to voluntarily participate in the survey. The surveys were administered to the patients with the help of other medical students with the use of a uniform script. The surveys for the female patients ask questions regarding their vaccination history, any previous histories of screening, and their general knowledge about the HPV vaccine, as well as their willingness to receive the vaccine. Part 2B surveyed the healthcare providers to gather information on the clinic's cervical cancer screening and perception of the patient's adherence to follow-up and treatment. And on the next page are some samples of the surveys that we administered. All the surveys presented to the participants were done so with the aid of local Luo-speaking translators. We advised all potential subjects that their decision to participate would have no effect on their care or position at the clinic. In addition, no identifying information was gathered during the process of the study. Now, Carli will discuss with you all the results and what we concluded with the data we obtained.
All right, so here's our results, and I apologize for my dog barking in the background. So for part 1 of the study, the results of the pre and post survey demonstrated the students' knowledge regarding the topics of cervical cancer, HPV, and determination of their willingness to receive the HPV vaccine significantly improved after the educational seminar. Can you guys hear me okay?
Yeah.
Okay, I'm sorry. My dog just started barking as soon as I started presenting. So our data showed that the average number of correct answers increased by 27.4%, which is a p-value of 0.02. We also considered answers indicating understanding. We considered yes answers indicating understanding to be correct answers and no to be incorrect answers. We also noted correct answers increased by an average of 4 students per question after the educational intervention. Additionally, the strongest increase in correct answers were for questions regarding HPV transmission and prevention, which increased by 78% for transmission and 50% for prevention after the seminar. So for the data from part 1, it showed that students overall had a good previous knowledge of vaccines, cancer, and the cervix. This indicated to us a good basic knowledge of vaccines and cancer, and from this we believe future prevention education can be built upon. In addition, the students' knowledge of cervical cancer and HPV improved significantly after the seminar, suggesting a positive relationship between HPV education and willingness to receive the HPV vaccine. So the results from the second part of our study this is the part that centered on female patient population aged 18 to 65 years old by analyzing vaccination history, cervical cancer screening history, knowledge of the HPV vaccine, and interest in receiving a vaccine. So in total, we had 79 participants. Only 23% of those had had a previous screening done for cervical cancer, with the majority having had only 1 screening done. And on the right side of the chart, you can see the ages at which these screenings were performed. So 17% was 20 to 29 years old, 33% was 30 to 39, 28% 40 to 49, and 22% 50 to 59. Unlike in the US, where screenings are done with pap smears, at this clinic they screen using a Lugol solution in vinegar, which changes the color of abnormal cells. And then based on that visual, they send suspicious lesions to another city for further management. So here are the results of our survey for this population. You can see here that 43% had ever received a vaccine in their lifetime. 62% had knowledge of what cervical cancer was, and 23% had been screened for cervical cancer previously. Notably, 72% had ever heard of a vaccine to prevent cervical cancer, or had not heard of a vaccine to prevent cervical cancer, and 97% would be interested in receiving a vaccine to help prevent cervical cancer if available. So from these results, we determined that the major barriers to HPV vaccination included limited knowledge of HPV, cervical cancer, and access to preventative services such as vaccines or screenings. And additionally, possible barriers to explain the low number of screenings could be a lack of education regarding the necessity of cervical cancer screens, limited resources from the clinic to keep up with recurrent screenings, and/or a systematic protocol for cervical cancer screenings. From the data and our experience in the clinic, the women surveyed were generally concerned about their health and were willing to receive the HPV vaccine if it were available to them. And we believe that that can really be used to focus on increasing education at the clinic in the future regarding preventative resources, and this will increase screenings and eventual vaccinations against HPV. So here's our results for the survey with the healthcare providers, and you can see we saw screenings by staff person per month, abnormal screenings by staff person per month in cases of cervical cancer in the last month. And you can see that notably the cases of cervical cancer in the last month was around 10. We had 10 participants. 6 of them said 0 for 1 to 5 and 0, 6 plus. So it was a low number. So the monthly average of recorded cervical cancer screenings abnormal results in cases of cervical cancer were less than 10 in a region where cervical cancer is the first leading cause of cancer deaths in women aged 15 to 44 years. This low number of positive cases can be attributed to the low number of screenings. Multiple challenges may contribute to the statistic: a lack of systemic screening protocol, funding for continuous screening administration, and overall resource scarcity. A further investigation on how the staff determines when and why to screen can help us further understand what additional specific barriers are present to this clinic. Also notably, even though we did only have a sample size of 10, and our results were inadequate to establish a statistically significant relationship, what we found both interesting and promising was that 7 out of the 10 workers believed their patient population would be interested in HPV vaccine and would be likely to follow up in their medical care. Also notable is that while we were doing a lot of the surveys, many of the healthcare respondents questioned why cervical cancer screening and patient HPV vaccine interest was being studied. And so educating the relevant staff members on the importance of cervical cancer screenings and advocating for HPV vaccine administration to the appropriate population could help with lowering the incidence of HPV and cervical cancer in the area. So in conclusion, we felt like the results of the study were very promising, as school-aged children and the female adult patient population were willing to participate in preventative services, including HPV vaccination, especially when provided with education and resources about such services. This was further reinforced by the perception of the clinic staff, who felt patients would be willing to receive HPV vaccines. And the major barriers to patients receiving cervical cancer screenings and HPV vaccines were limited education regarding HPV and its prevention, a lack of clinic resources, and a lack of public knowledge on what services are available to the clinic population. So study limitations that we found included small sample sizes of the clinic staff and students. Additionally, a small number of the surveys had some inconsistencies, such as with the student surveys. Some of them had all either like yes answers or all no answers, maybe indicating some misunderstandings of questions due to the language barrier. We administered the surveys in English and used students in the area for translators who were like high school age. And they all spoke English, but at varying levels. And so this could have led to some misunderstanding among participants when answering the survey if the translators themselves didn't totally understand what was being asked. So future studies could expand the project to increase sample sizes and provide training to translators to increase understanding of the survey. So next steps from this pilot study, We would like to act upon the HPV vaccination and cervical cancer screening barriers at the clinic. This would involve improving public awareness of preventative services available at the clinic and providing more education to a larger population of students and patients regarding HPV. Additionally, we hope to conduct a longitudinal study to see the long-term effects these measures will have on cervical cancer rates in the area. Also, prior to COVID-19, there were plans to implement a free HPV vaccination program for the female population in January of 2020. And so we would like to follow up with that and see how successful that's been. We know COVID may have changed how it was implemented, so that would be something we would like to follow up on. We hope by improving awareness of the HPV vaccine and cervical cancer screening services that this could have a major positive health impact on the local population. So in conclusion, future goals for both Farzeen and I. For me, I am applying to a pediatric residency. I'm hoping to be involved with global health in the future, in pediatric residency and beyond. In my ideal world, I would love to be able to come back to this clinic and carry on our research that we've been doing and help with implementing these, addressing these barriers and addressing the educational barriers especially. So I'll turn over to Farzeen with her future goals.
So to piggyback off what Carli said, I also want to make sure that I have, ample global health opportunities in the residencies that I've been applying to. I'm currently applying for internal medicine, and hopefully will want to specialize and do a fellowship in oncology with a also specific focus with GU cancers that would include cervical cancer in the future. And so I also stand by this in all my interviews. I always say that this trip was hands down one of the best experiences of my life. It really pushed us out there to really think for ourselves and not just as a student under a preceptor, almost at like resident level thinking. And I think it really helped with our confidence. And so I would love the opportunity to go back to and work with Banyo Mission Clinic, and then also hopefully expand this project with future KCU students as well.
Okay, awesome.
We just have one more thing. We just have some slides with our references. This is Dr. Banyo here, Dr. Tupa, Dr. Desai, and Dr. Tyler. And we just wanted to say thank you to Dr. Banyo and all the volunteers and clinic workers at the clinic who helped us. Without them, this wouldn't have been possible. Thank you.
Yeah, sorry to cut you off. Thank you, Carli and Farzeen. That was amazing. We really appreciate this talk because I think it's going to give students that have interest in the global health track some of the opportunities that are available through KCU. So really kudos to you guys for bringing this to us and for conducting this research. If there are any questions, we will definitely field questions at this time. But I don't see any hands up. I know, oh, I see Dr. Johnston has a question. Okay, go ahead, Dr. Johnston.
Yeah, Farzeen and Carli, thank you very much for the presentation. And I applaud you for your admirable goals, as both of you are pursuing areas that you definitely have an interest in. So I applaud you for that. I just feel, granted, limitation of sample volume is of concern. There's no question about it. But while there, did you pick up anything relevant to that's unique to that part of Kenya, such as maybe a religion or crime or sex trafficking or anything like that that would have some influence pertinent to a person's intimate behavior? Is there anything else that, other than lack of resources, that you say, there's a sizable number that who are under the influence of something? Anything that's that's different in that part of Kenya?
So the community that we worked with was a relatively conservative community. I believe a majority of the people in the community are Christian, and they try to preach and practice abstinence. But along with that, they don't really have any kind of form of sexual education as much. That's something that I think also might contribute to with the spread of STIs and also HIV. We also saw quite a few patients with HIV as well. A lot of the patients were also embarrassed to talk about their sexual practices or anything regarding pap smears, cervical cancer, or anything regarding to that. That was one thing. And the other thing I know that Dr. Banyo had mentioned while we were just discussing general care at the clinic is that some people don't know the necessity to go to the clinic. A lot of them do come whenever they see that the American students are there. They don't necessarily take advantage of the resources, and some of them will also go to witch doctors for treatment as well. And so sometimes when they present to the clinic, some of their disease processes have advanced pretty far.
Thank you.
Okay, thank you. Guest, I think that's Dr. Schmidt. Go ahead, please.
Hi, thank you for calling on me. I have a question for you. The response, sorry, my son's in band class. The response of doing the all yes or the all no, do you think that part of that may have been kind of a deference to the authority or the status of being American? And if so, what could be done differently to mediate that?
Yeah, I mean, we did have the number of surveys that we did notice that happen on where they answered either all yes or all no. There was only maybe like 3 out of a total of 29, and we didn't really use it to analyze our data, but that definitely could be, it was in there, but we kind of marked it as a little bit skewed perhaps. And yeah, and sorry, I'm blanking on what I was going to say.
That's okay. So I was wondering, do you think that they sort of responded to your being American? And you know how like a lot of kids will, yes, doctor, no matter what the question was. So I think you have a cultural difference, and they were sort of being deferent to your status as American and doing an all yes or an all no because of that. And if you saw that, what could be done differently to try to help them be a little bit more accurate in their responding?
I think one of the ways to possibly solve that is just spending also more time with them for them to be more familiar with us. I know that's something that's out of our hands just with the constraints of how long the trip could be. I do definitely think that could have played a role too. Some of the kids were, obviously a little bit uncomfortable with like the subject matter that we were talking about. And then when the conversation got a little bit serious, talking about like STI prevention, and as well as, we also kind of introduced the idea of consent as well, because that was something that the clinic staff had encouraged us to talk about. I know some of them felt just uncomfortable and wanted to get out of the process and not really participate, just from like the attitudes that, at least I had interpreted. But, I think that I really don't know how we could necessarily overcome that other than introducing sexual education a lot more often to the community, and then having them just be more familiar that there are medical students from America that do come along. I think that's just something that might take time, and it's just more exposure based. So that's, I guess, how I would kind of approach this situation.
Yeah. We did have the translators. The translators, a lot of them were not much older, or just a little bit older than the students, and they were kind of working with the students doing the surveys and translating for them. So maybe if they felt more comfortable, I think like Farzeen said, just with maybe some more time, so they, were more comfortable with answering. And we didn't necessarily say which answers were like the right answer either. So, some of them maybe, but yeah, that is a good thought.
And I think what would definitely help in the future is to maybe have like a pre-training session for the translators specifically, and getting them comfortable with translating, because there wasn't that much practice, so they were kind of winging the translation. So I definitely think that things were lost in between.
Okay, thank you. Dr. Schneider, I see your hand is up. Go ahead, please.
Thank you. First of all, girls, I congratulate you. Congratulate you on presentation. Presentation was excellent, both if we took visual, was concise, clear, and orally you presented excellent. You did very good job. It sounds very professional, and I congratulate you and your supervisor or whatever on this, making this presentation. And after that, I had a question, but when you answered Dr. Johnson's question, I derived my answer from that. So I don't have it. Just last question. Did you have time to go for safari?
Yes, we did. Yeah, we should have added some pictures from it, but it was such a great experience.
Yeah.
Can I ask you, you've seen those people for a few weeks, all right? So what's the biggest difference between them and our kids?
So I actually keep in touch with some of the kids, or one of the kids in the program through WhatsApp. And one of the main things that I've talked to them, and I think she's the same age as my younger sister here in the States, like they're both about like 14. And one of the things that I noticed is I feel like they just kind of have more of an appreciation of education and so many of the things that we take for granted. One of the things that really stood out to me when I was there, and this is for like an older patient that we had, she was like in her 60s, came in for back pain, and I gave her one of my old sweaters that I decided to like bring for donation. And then one of the things that we could only give her for her back pain was Tylenol. And she started tearing up and crying and saying that she was going to be my Kenyan grandmother and she wanted to take me home and feed me. And that's just something that, just made me feel like it really struck a chord with me. And it just made me realize that there's so many things that we take for granted that's limited there. And I think that's just one of the main things, major differences between, I guess, our lives here and their lives there.
It sounds, I traveled neighboring country, which is actually in the past, Tanzania. In the past was Uganda, Kenya, Tanzania. It's one colony, British colony. But what struck me is, of course, there are areas where people are very poor, but they are happy. They just simply happy people. It doesn't matter what they possess and what they have. They just smile. They're just very, very nice people. That's what my impression. And you also noticed that. Absolutely.
Yeah.
All right. Congratulations. I'm very happy that you've seen life like that. And it makes a difference in your life as a professional.
Yeah, we really wanted to have a positive impact and not just kind of play the savior role by just going in for a couple of weeks. And I think that's really important. And that's something that happens quite often with any kind of mission trip. So the kind of content that we wanted to bring was something that they could use in the future for themselves and make their own.
Yeah, thank you. Thank you, Dr. Schneider, for your comments. Dr. Wolf, I see your hand is up. Go ahead.
Yeah, your last point there was something that I thought is so important, that savior role. I mean, being able to do something that is relevant to them afterwards. I was curious if you could follow up a little bit on what the limitations were in terms of their ability to assess the samples. If you're going to do all sorts of screening, all of a sudden you're going to have all sorts of samples to check. And so to what extent are they going to be able to address additional infrastructure challenges along the way?
So most of the patients that end up having abnormal screenings, they're directed to go to Kisumu or like a larger medical facility for further treatment. That's just, and that's why we wanted to move the focus away from screening and Lugol solutions and have put the focus on the HPV vaccine, just because it's harder to follow up with the further treatments in those regions because there isn't that much government funding and support. And I'm pretty sure this is probably more put on the back burner now because of COVID-19 and the need to push out vaccines over there and treatment for COVID over there. And so, but mostly if you wanted further treatment, that's what they would send you is to more, I guess, higher care facilities.
Thank you. I had one question that I was curious. Did you guys think about, or did you provide any kind of handout or literature or any pieces that would stay there beyond, you know, your visit that they could use as educational pieces afterwards to kind of continue this mission?
We, so the presentation that we did at the educational seminar, we printed off those slides and we left them with the coordinator there, Marilyn, for future presentations. But I don't think we didn't leave any other handouts there, did we?
No, we didn't. We did. Yeah, we kind of try to keep the language as minimal as possible, as basic as possible. And so just because we want to make sure that things translate properly, sometimes there's some Lua words that they don't have a word for our words and vice versa. And so if anything, I would love to develop more of the content and make it more appropriate and maybe work with other people that are, I guess, like cultural ambassadors to make sure that we can come up with good content for that community.
Yeah, and one of our big, oh, sorry.
No, go ahead, Carli.
I was just going to say, one of our big goals for this study was we didn't really know what we were going to find. Like, we, so our, so what we wanted to do was find out, you know, like, what are the barriers? What, you know, we just wanted to gather as much information as possible so that, you know, we were hoping on a future trip, then we could take in like all the educational stuff, all the informational stuff, and then start to address those specific things and leave them then. So, yeah.
And like what Carli, sorry, go ahead.
I was going to say, I think that's perfect because now it's given you kind of a foundation that you can build on, and you know, by continuing to work with the community and the country itself, bring pieces that can be used, you know, everywhere, not just there. So yeah, you guys have taken the first steps. Like I said, you have a nice foundation, and I'm sure your future aspirations and career paths will, you know, hopefully continue down these roads where you can continue to contribute in the ways that you want to globally.
Thank you.